Good afternoon, everyone, and welcome to this session where we're going to be discussing region-wide project looking at inequalities and access to children and young people's mental health services. My name's David Callaghan, and I'm a senior consultant at the Strategy Unit. I know many of you have contributed to this work, and we really want to use this session to elicit your initial reactions, so please do get involved. If you've got any questions as we go through, should be able to use the Q&A function, and we'll try and answer them either during the presentation or at the end. I should say that we're going to be talking about findings at a regional level today, but we'll be releasing system-specific findings alongside the full regional report in a couple of weeks. And I will also say that we're using Teams Live for the first time today, so if we have any technical issues, please bear with us. It's been I suppose it's been a year of firsts for a lot of things technology related, so just ask you for your forgiveness if anything goes wrong, but obviously hope it doesn't. So let me start off by just introducing you to the project team from the Strategy Unit. There's been a lot of us involved at some point during its life. Andy Hood, with whom I'll be sharing presentation duties today, has led this project and produced all the quantitative output supported by Tom and Alex. Abby has led the qualitative research bit, supported by myself, Richard and Ellie. So that's all of us. I'll kick off briefly by outlining how this project came into being before handing over to Andy to talk a bit more about what we've done. So this piece of work has been conducted on behalf of the Midlands region through its Decision Support Network, which is a collaborative working arrangement, I suppose, across all of the ICSs or STPs in the Midlands, as well as directly commissioned services to, amongst the other things shown on this graphic, commission analytical projects that make sense to be done once across the whole patch rather than every system doing them individually. So 3 were selected for the last financial year, this being the second. You may have seen the project report focusing on inequalities and access to planned care, released last month. We've also got 3 more projects planned for this financial year that are referenced on this slide. So if these titles pique your interest, please do get in touch with us. So that's the provenance of this project. I'm going to hand over to Andy to take us through the initial detail of what we've done.
Yeah, thank you, David. So just by way of setting the population context really for this project again, why it's such an important thing essentially. So again, some of these numbers may be familiar to others working on a regional footprint, perhaps not so to others, but there are many children and young people living within the region, over 2.6 million more if you include the kind of preschool and infants as well. And obviously each of those individuals has a very different set of circumstances which dictate to some extent their mental and physical well-being. So ethnic and cultural diversity and how that varies across the area. Again, in just picking out 2 examples at the extremes, so Hereford and Worcestershire has a relatively less diverse population, Birmingham, Solihull very much more so, and that follows through for many other things as well. So thinking about social material deprivation, again, those 2 same extremes are the ones in the Midlands region. Things like access to public services, community services, again, is very different depending on where you live and the circumstances in which you find yourself, access to housing, education, green space, just to name a few. And also the provision of health and care differs for those populations. For example, Lincolnshire has fewer GPs per head of population than the rest of the borough, of the area, not necessarily a good or a bad thing, that's just an observation. It may be linked in terms of how people find, navigate and sort of support their mental well-being needs. The Shires, for example, also have less flexible access to, for example, acute services and beds, so may have to travel further, go out of area if they want to find some kind of service to support them. So it really is no surprise that children and young people have very different experiences of both mental and physical health and the availability of services to support them. Okay, next slide, please, David. So the implications really, and this is the critical bit of why this is so important really. So slow or no action in terms of improving, preventing, mitigating ill mental well-being in children and young people can have really serious effects, thinking about the whole life course and sort of future chances of prosperity, I guess, in broadest terms. Other people have articulated this much better than we, but there are things particularly in work that we've done previously around life expectancy inequalities, the stark gap between those with mental health difficulties and those without, in terms of sort of longevity of life on a really basic but crucial level. So for men, that's nearly 20 years, for women 16 years nationally is the gap in years of life lived. And obviously your experience throughout childhood, adolescence very much affects your resilience, your ability to cope with stresses that often occur throughout adulthood as well. Specific consequences of not supporting children and young people's mental well-being, and this isn't an exhaustive list, but self-harm, substance misuse, suicide, involvement with the criminal justice system, and of course the linkages with poor physical health as well. That's a two-way, multi-directional street, I guess. And the economic costs are very stark as well. Nationally, LSE and Centre for Mental Health estimated, and this is a few years ago, it's likely to be more, over 100 billion each year in terms of the total social and economic cost of poor mental well-being in England alone. But there is good news, obviously, that the benefits over those costs in terms of early intervention and prevention are pretty good when compared to some other types of issues. So for every cost benefit ratio. So £3 saved for each one invested effectively in prevention and early intervention services are the averages around early intervention and prevention for children and young people. So again, this is a salvageable situation. It's not necessarily that everyone will end up with adverse outcomes. There are things that we can do to improve the chances, improve the trajectories of people's mental well-being. Okay, next slide, please. So it's kind of a rhetorical statement or question, I guess, about why is this particular issue for the Midlands? Well, in terms of the national ambition, and I use the term advisedly, I won't jump on the soapbox too much about the nature of this particular access target, but the Midlands, in terms of all the regions across the country, is the worst performing in terms of this access measure, which is the national kind of standard ambition around getting young people into services, which is set at 35% currently. I'm sure it will be revised in future versions of long-term plans and forward views. But when we start to break that down by CCGs as well, so thinking about within that Midlands area, there is sort of great inequalities as well in terms of how many young people are supported through their things. If you can click on the next, please, David. Thank you. And again, so yeah, that's just the distribution for CCGs. Most obviously as borne out by the regional values, but most are well below that national ambition. We go from, again, the extremes in terms of only 1 in 5 children, young people supported in Sandwell, for example, but that's almost 1 in 2 up in North Staffordshire and Stoke-on-Trent. So wide variation. Yeah, is that access? Is that provision of services? So there's many things potentially which could lead into this kind of metric and try and understand it. Okay, next slide, please. So it is a tremendous scope that we've tried to cover in this. What we've essentially tried to do is boil down what we think are the key kind of questions that we can try and answer with some kind of additional fresh insight on this issue, or just reorganising current insights into a more manageable way. So the kind of questions: which groups are most affected by poor access? How do we potentially improve this? Are there differences in perspectives around access, particularly between service users and the service providers? That's quite a key dynamic. And what are the consequences of poor access? How might we mitigate them? And which factors might determine demand or need for acute support through into adulthood and across the rest of the life course, as I've said. So there's various things we've done to address that. If you click through the next slide, David, I'll draw out a little bit more detail about the things we've done. So evidence clearly plays a key role in this, trying to understand this issue. So a colleague, Richard, reviewed a massive amount of volume of articles, reviews, grey literature, to try and understand, distill, combine, categorise all of that into a useful thing for people to take away. We have got a specific evidence map which will be posted to DSU website and resources in the future. So as I've already alluded to, we had loads of data and analysis we sort of spec'd out to do, looking at unmet needs, looking at pathway inequalities, looking at sort of cohorts over time and potential future needs. We also, as David in the intro suggested, did lots of qualitative work with stakeholders and with children and young people themselves via an online survey. So varying levels across systems, but as David said, this is the regional perspective on some of that work really. So pulling out the key themes that are resonant across most areas or all areas within any particular area. Okay, I think it's back to David now for an overview of these.
Okay, so
David, sorry.
Go on.
Yeah, so yeah, I'll just carry on. Sorry. So these are essentially the culmination of all of this, and you'll see borne out lots more detail on each of these in the overall report. We'll dip into some of them in a bit more detail through this presentation as well. But the first consistent message which comes out of all of the analysis, triangulating everything we put together, is around the complexity of the systems and the way that children and young people navigate them. That in itself is a barrier to access. But in particular, this is resonant and consistent among several key population groups. That's to say, those in lower socioeconomic groups, those in the Black and Black British groups, those transitioning through to adult mental health service from adolescent age groups. I mean, specific users of learning disability and autism services have specific challenges which are unique to that group. Why is this important? Perhaps the question is, why is this not important? But inequities in access to services may exacerbate those health inequalities, as I've already stated, existing disadvantage and adversity, and sort of impact on mental health throughout the entire life course, which is clearly something we want to avoid and offset in terms of what we try to do and work with these young people. So the second key message, access to some specific services and some specific subgroups of mental health conditions, I guess, is much poorer than others. The focus of this, because it is such a stark issue, is eating disorders, this presentation, but again, there'll be information on things like conduct disorders, hyperkinetic disorders, behavioural disorders, self-harm, and looked after children as well. So the issue particularly around eating disorders, it's a known inequity. There's serious gaps in terms of provision and satisfying what the demand is potentially for services. There's very long average waiting times, which have probably been compounded throughout COVID. Many urgent referrals aren't seen within a week, which is the specified guidance for dealing with urgent referrals. It's actually fairly similar for routine ones as well currently. The inequalities are growing, particularly some groups, minority ethnic groups and male, people with eating disorders specifically. In part, some of this is due to GPs potentially delaying referral or young people themselves delaying seeking support. So there's issues around communication, what is available for people to support. But this is being addressed in some systems better than others. So there's a case of looking at where best practice can be picked up and used by other areas. Why it's important, again, I think that message has probably come through from the others, but I think the point here is that COVID has really sort of exacerbated some of these particular issues around eating disorders. It's one of the services which has seen the surge in demand actually manifest and increase well above expected levels during the pandemic and all of the various lockdowns. So third overall message, through mainly the interviews with the system leads, people working within systems, it's quite clear that equity isn't particularly on the radar in terms of longer term strategic objectives and improvement. And again, there are various reasons for that, some based in resource, some based in finance, some based in what the national ambitions, again using the term advisedly there, for access are. So the focus on that rather than actual inequity within that particular metric. So again, we'll unpick some of that later on in the from a qualitative perspective in the presentation. And finally, more of an overarching kind of theme again we've picked up. So, you know, the provision of services is certainly not distributed according to need. There's various reasons again for this kind of mismatch in supply and demand, seemingly an over-reliance on CAMS rather than early intervention and preventative service. That seemingly comes more from the actual service user side, but also from within systems, inconsistent utilisation of services, both NHS and private. Clearly there's workforce challenges. That's largely beyond the scope of this piece of work, but certainly something that local areas should consider. And again, from a national down to regional and local levels, a reactive investment in services rather than having a longer term needs-based strategy for how to support children and young people. The rhetoric of improving preventative and early service, which we see through various strategy documents, 5-year forward view for mental health, long-term plan, which are all, you know, very good policy initiatives. but we haven't really seen those translated into a better experience yet. It may become, there may be a longer lag in some of those investments, which obviously we will pick up over time. So I think we're going to explore more in detail after this section on unmet need, which gives a bit more detail of how we've kind of broken down that. So this is slightly different from the way that access is measured according to that national target and ambition. So this is looking at specific subgroups, looking for the estimated prevalence. So Alex is also on the call. If you have any questions about this, please put them in the chat box and we'll pick those up. So yeah, looking at measuring who we think in the population has any particular specific conditions or support needs, and then looking at the systems themselves, the data from mental health services data predominantly, to try and identify which of those people are currently being seen within services. So again, it varies both within these clinical groups. You can see eating disorders at the very bottom because these are ordered in terms of that kind of supply ratio or level of unmet need, whereas looked after children seem to be better catered for within systems, albeit they have specific issues around retention and sort of revolving door behaviours in terms of mental health. So the next slide again, David. So just breaking that down again to a system level. So looking at the STP/ICS breakdown of this, again, sort of some very large numbers by systems, and actually a significant variation within the Midlands and also nationally even greater variation. But so again, taking the top examples there, so Shropshire and Telford and Wrekin overall seem to pick up around about 1 in 10 of their sort of children and young people with mental health needs, whereas Lincolnshire at the other end still may not necessarily be a positive thing, I suppose, but 3 in 10, so 3 times the level of children and young people picked up by that system and offered kind of acute specialist support to try and manage their needs. So that's the kind of variation, that's the geographical dimension, I suppose. There's very much a lot of very complex issues tied up in those areas. So we'll now dip into a bit more detail on each of these issues, show you some of the work that we've done which contributed to our sort of picking out of these as key messages. Thanks, David.
Thanks, Andy. So let's get into a bit more detail about our first key finding. So that's the one that the complexity of navigating children and young people's mental health services is in itself a barrier to access, and that this is experienced more acutely by certain groups. So just a heads up, as we go through these findings, we'll be sharing data from all of the source materials, so the published literature, the survey, the interviews and the quants, and we'll be shifting back and forth between me and Andy as we do so. To help you read the slides, the grey boxes are published literature, the black ones are from service user comments, and the orange ones are stakeholder interviews, and that'll all make sense as I start to go through these slides. So the survey provided us with evidence that children and young people themselves find services difficult to navigate. So this chart on the left states that nearly 50% of respondents found finding the information they needed to access services either very difficult or difficult. And the quote on the right of the slide is reflective of the anxiety that came across from several respondents when trying to access services. And I'll give you a second to digest these quotes as I put them in front of you. The stakeholders we interviewed provide us with an extra layer of depth, I suppose, to these findings. So many suggested that the complexity of services meant that it favoured those who figured out how to navigate them and created a barrier to those who didn't. So of course, you know, parents play a central role in this. So where a child or young person has parents or a parent who can commit the time and resources to understanding the system, and for want of a better word, you know, assertive, this plays an important role in supporting access, but conversely does the opposite when these factors aren't in play. And this barrier could be more acutely felt by some groups more than others. So this is the case for those from lower socioeconomic backgrounds. So the published literature in this area tells us that poverty and morality combined make accessing services more difficult, and this was also reflected in the interviews. The restrictions in terms of when and where appointments take place also provides a barrier to access, and that virtual treatments can mitigate against this. And these have certainly been accelerated during the pandemic response. And when we discussed this issue with stakeholders, we heard that there were concerns about digital exclusion where services had been moved online, and a blended model might be required and indeed preferred. They also mentioned the cost of attending appointments, both in terms of parents taking time off work and the costs of travel, parking, etc. And then co-production was also picked up in this quote at the bottom of the slide, with specific reference to those on low incomes. So interviewees questioned whether those who design services really understand and therefore can mitigate against some of these access barriers.
Thanks, David. So I'll spend a little bit of time just explaining what these charts mean, because you'll see several of them dotted throughout the next series of slides. So these are elements of the pathway that we kind of described in total terms, which covers the way that people are referred into services, the level of people that are offered services once the referral is made, the kind of intensity of treatment, the attrition or the dropout rates during that treatment process, and then the ones who are then potentially re-referred after their discharge. So this doesn't cover everything of the pathway that we've looked at, but covers particular elements. So on the left here, particularly in terms of IMD, so we break down each of these into the characteristics on the bottom axis and the proportion of those, or the rate for each particular dimension of that pathway. So on the left there, you've got the unsuitable referrals, and that's unsuitable from a service side, so sort of not at threshold or suitable for a particular service they were referred to, or unsuitable on the patient side. So the patient, even though they might be offered a treatment, actually didn't take up that option. They kind of withdrew before they actually received any support. So that's two sides of the same coin, really. So you can clearly see there's a gradient in terms of deprivation there, 1 being the most deprived and 10 being the least deprived in terms of the IMD deciles. The most deprived groups are less likely to receive a treatment after referral on the whole, particularly marked in that second IMD decile. In terms of the intensity, there's not much difference in terms of the length of duration that most people are in contact with services for, or their contact frequency. However, all of those lower decile groups actually receive less contact time once they're in a consultation room, or once they're sitting in front of a clinician or talking on the phone. So that might be something that may well be suitable, or it may not be, but that's something potentially to pick up in terms of how services cater for those patients. You can also see this follow through in terms of the re-referral. Those that are discharged from each of these deprivation deciles, those in the 3 most deprived groups are significantly more so likely to refer. Well, you know, over 1 in 5, nearly 1 in 4 are likely to refer back into services within the next 12 months. Clearly, they're not being supported in a way that gives them that kind of long-term mental well-being. Okay, next slide, please, David. Okay, so here's just another graphic. Again, I'll spend a little bit of time talking about this. So we also looked at, and Tom could better explain this in more detail perhaps, but we'll publish loads of information on the cohort work that we've done. So looking at a group of children and adolescents from 2008 and 9, we kind of followed those over a 10-year period in a linked way through HES data sets and the various versions of mental health, minimum learning disability and services data sets. To look at the nature of the support over that 10 years. Were they in contact with services for a small period of time, for intermittently all of that period, and so on? And these are from a demographic point of view, the kind of impacts that those factors had that we studied to say whether someone was more likely to have prolonged support needs over the next 10 years or shorter term support needs that the system seemed to satisfy. Clearly, this is all on the basis of being in contact is bad per se, and being out of contact means that people are better at managing themselves. But you can clearly see we've pulled out the IMD categories there. 3 is the reference category effectively for this particular analysis. There is the central line. So you can see those in the most deprived, again, IMD group 1 quintiles in this case, are more likely to have prolonged support needs, and those in the most affluent IMD 5 are less likely or more likely to have shorter term support needs. And obviously, because this is a complex nature, all of the co-occurring factors such as ethnicity, such as age, gender also play into this as well. So you can start to see how building up a profile of patients can lead you to make assumptions about how their future needs might play out as well. So useful. Like I said, there'll be lots more that we publish on this cohort analysis that we've done as well. Perhaps a separate webinar almost to try and understand some of that data.
Cheers, Andy. So we also found that ethnic minority groups appear to experience unique access barriers, and this is from the QUAL data. So again, looking at the published literature tells us that Black and Black British groups utilise CAM services more than other ethnic minorities. The Asian females have got much lower referral rates to eating disorder services compared with non-Asians. And that South Asian children, young people with intellectual disabilities or learning disabilities have lower use of mental health services compared to white British comparison groups. And although there was limited discussion of the role ethnicity plays in access from the survey, this comment in the black box suggests cultural stigma around mental health in some demographics made accessing services more difficult and raises the question of how we overcome such barriers. But broadly, stakeholders told us that although anecdotally they thought that some ethnic minority groups use services disproportionately less, there isn't really any robust analysis of this in most places. So there's little understanding across the Midlands as to where inequality of access exists, and we'll pick up a bit more on some of the reasons we heard for this later in the presentation. And the second quote here points to this idea of stigma again, but on the part of services themselves and the workforce lacking the experience in some cases of working with diverse communities. So those were some of the qual findings around ethnicity.
And a few more of these graphics here on the pathway in terms of the black ethnic subgroups. Unfortunately, due to data, and it's another soapbox we'll probably try and avoid in terms of the data quality and suitability of the ethnic coding within routine data sets, but particularly for those black subgroups that we've aggregated, again, that tended to spend longer in services, see professionals for clinical contact much more frequently, but again, in the black group, spend less time. So that might be a service model thing, that might be a cultural issue. There are many other things, but again, I suspect some of the reaction to this kind of analysis is to try and unpick with those particular communities and subgroups what the issues are in terms of their pathway and the delivery of services to them to fit in with their social, cultural requirements and so on. The re-referral for the black group subgroups again is particularly stark. So, you know, almost 1 in 3 again are sort of seen back in, kind of entering that revolving door type thing where they're discharged from services and come back in for additional support further down the line. So are we discharging them too early? Are we discharging them without actually addressing what their underlying mental health needs are? So there are various questions to explore by local areas again in terms of those things. And picking out again from the cohort analysis we've done, the logistic regression. So again, the ethnicity, the black subgroups, in terms of ethnicity, is the most likely to drag that population group into the longer prolonged support needs, as opposed to more short-term support needs.
And we've also got some findings relating to inequality in access for those transitioning between children's and adult services. So here, the published evidence points to the different offers of adult and children's services creating a challenge when it comes to transition, with adult mental health services providing less support for broader well-being. It also suggests that there is lower engagement with parents in adult mental health services, but crucially, the evidence suggests we don't really understand and therefore able to respond to the challenges of transition because of a lack of robust evaluation of transition programmes. And we've got some evidence from the survey around this as well. So we heard about some service user experiences, and this one being one example where the service user had a difficult transition experience that really wasn't well communicated. And stakeholder comments pointed to inconsistency in the transition process, with those between 18 and 25 having challenging experiences. And this comment at the bottom suggests that the older cohort of young people are really struggling to get the support that they need.
So just picking out again from the kind of pathway and cohort work there. So there are some very stark, again, kind of differences in the experiences of that older age group that David's described there in terms of the transition. So again, the suitability of, again, thinking about that's from a service and a patient perspective, the unsuitability of patients referred into services. So again, that could be that there aren't suitable services, could be that they don't fit the needs of those particular age groups, but they seem to have higher than usual levels, again, sort of 1 in 8, 1 in 7 potentially of those young people don't have anywhere to go to in terms of that acute specialist support. So where do they go to outside of that? Is it primary care? Where else in the system do we cater for these people who don't necessarily fit in with what our service model is providing for them? Even more significant, I think, are the differences in terms of the re-referral, so that revolving door effect, almost up to in the oldest age group. So that's the point at which most sort of children young people services stop and transition to adult at the age of 25. Almost half of those will refer back into a specialist service within 12 months of discharge. Clearly there's an issue there in terms of what is offered, what is required for those particular patient groups. So yeah, the transition is very much an issue. That's possibly, you know, anecdotally known within systems, but I think this gives it a little more credibility. In terms of the factors, in terms of the cohort and the longer term support, age is a mild, but it is a factor there in terms of suggesting that the longer term support needs, if someone's still in services at an older age, logic dictates, I suppose, to some extent that they will potentially have much longer prolonged service needs over time.
Okay, so and finally for this key finding, we wanted to touch upon the experience of those with LD and or autism, because although the quant data hasn't focusing on the impact of LD and autism on access, it came up a lot in the interviews and also the survey, so I thought it'd be important to include it here. But it clearly needs further development because the evidence base around this issue is also very limited. But what there is tells us that the transitioning process is especially critical for those with the academic term seems to be intellectual disabilities. But we also heard evidence from some service users with autism. So here, one person felt that mental health services struggle to work with people with autism. There was another quote from a young lady who suggested that that young women with autism were disproportionately accessing services less as well. And like I say, this is something that came up in the interviews across the Midlands, and no one was really confident that they cracked it. So it's reflected, and that's covered in the quote at the bottom, that the process of diagnosing autism created a barrier to accessing mental health services, and that this diagnosis was especially hard to come by. So it'd be interesting to hear if that rings true with people. So those are some of the main themes relating to why the complexity of services has acted as a barrier to access. So I'll hand back to Andy, who's going to talk us through some of the issues specific to eating disorders.
Yeah, thanks, David. I won't spend too long on this section. I think some of the background was already covered in terms of the introduction and the unmet needs overview. But yeah, again, this is something that has become apparent throughout that unmet needs analysis, throughout the interviews, particularly in this case with the systems who acknowledge that there are issues in terms of in terms of access, in terms of capacity, in terms of funding and workforce, and a whole basket of things which contribute towards this vast level of unmet need, I suppose. We know that obviously the average waiting times were poor before, that there are issues in terms of both urgent and routine access. These haven't improved over COVID and have in fact exacerbated some of those issues, we suspect. There's certain things around stigma of certain service user groups, population groups, and particularly because this tends to manifest in the kind of teenage, adolescent age groups more so than in very early, although there clearly are some early issues. That tends to have its own issues as well in terms of peer pressure, in terms of school, in terms of stigma as well. So that might be contributing some of the issues towards this particular problem. And again, the evidence suggests that this is known to be a particular issue with certain minority ethnic groups within children and adolescents. So yeah, just to refocus again on that unmet need and how that varies across the Midlands patch, as it were. So again, just highlighting that supply ratio, as we called it there, but again, it could be that could be a prevalence or an unmet need percentage, I suppose. So pretty much 2% of those with a potential need, and that's not just any kind of general need. That is pretty much the diagnosis level or acute needs, and what the system is actually seeing in terms of throughput of people for those specialist types of disorders, either in terms of being referred into, in terms of the diagnosis they've received, or the reasons for referral. So I've used a wide variety of sort of code frameworks to try and identify these people within the system. So clearly across the patch there is a variation, and this chart is slightly misleading in some way because it suggests that some areas across the country don't have any levels of unmet need, but this is all on a relative scale. So I think even the best nationally in terms of identifying and supporting children with eating disorders is probably only about 5 or 6%. So there's still vast levels of unmet need. But yeah, in terms of the Midlands area, so Derbyshire, Coventry and Warwickshire, Staffordshire, Black Country, Nottinghamshire are the ones kind of above that line, as it were, in terms of those top 2 quadrants and the relative worst levels of unmet need. And also those latter 2, Black Country and Nottinghamshire have the highest levels, or some of the highest levels of potential prevalence. So we're talking large numbers and large levels, relative terms of unmet need as well. So it is a particular issue across the Midlands, and in some areas more so than others.
Thanks, Andy. So now we're going to just get into reflecting back some of the reasons we've heard as to why inequality of access isn't particularly well understood. So this has largely come from the stakeholder interviews, and we heard that analysis of access equity within children and young people's mental health services just wasn't common practice. And a few reasons behind this were suggested. So firstly, that activity data is inadequately recorded and submitted. So there's obviously a lot of variation by system and provider, and there are lots of providers of children and young people's mental health services. And we heard that lots of work has been done with non-NHS commissioned providers to improve data recording and quality, and progress has certainly been made, but variation still exists. We also heard that providers are not asked to report on inequity of access, so the national requirement to report on general access rates maintains the focus on that measure. So concentrating on this target doesn't lend itself to prioritising reporting equity of access. And we heard that limited awareness on how to appropriately record demographic data in local systems restricted understandings of access equity. So, for example, reporting of ethnicity is a blunt instrument which often doesn't allow for distinguishing between different factors at play for different ethnic minority groups. Just as an example of that. And at the root of much of this is the fact that there is a lack of dedicated resource for data collection and analysis around inequity. So analytical capacity does need to be provided to better understand this issue. So those are some of the key points that came out of the interviews. And of course, although we've focused on the challenges here, but lots is already being done within systems to improve access to children and people's mental health services. So we did want to review this. This slide describes the different initiatives we are aware of across the Midlands to support access to these services. Now, we're not suggesting that this table is comprehensive. Before anyone says, we're doing that. I'm sure there is lots more going on, but we've been limited by what we've heard and what we're able to deduce from desktop research. So, on this, as much as anything else, really welcome your reflections. But broadly, though, it shows where the effort is being concentrated, and some of the other things that systems are doing that are less prevalent. So, for example, you can see single points of access of varying types, mental health support teams, and online offers are widely in place. But there's some more novelish initiatives being used as well. So, for example, CAMS liaisons in primary care to support referral. You can see initial assessment teams to shorten waiting times for a referral, and also crisis cafes we found examples of in some places. So although it's not in the scope of this work, there's much clearly we can learn from each other, especially in these areas where novel initiatives are in place. And we suggest certainly the DSU network is designed to support this kind of shared learning, and hopefully as we start to run action planning workshops around this work, we can start to draw out some of that. And a more detailed description of these initiatives you'll be able to find in the main report that's released in a couple of weeks. And any review of these initiatives might be helped by this chart from the survey findings showing how children and young people are accessing services. So you can see that schools, primary care and CAMS are by far the most prevalent access routes. And this also backs up the finding that non-NHS services are being used inconsistently. But we don't really understand the reasons behind this. We've had some suggestions, one of which is that there's poor perceptions of the quality of non-NHS services, I should say, which came up in the interviews as a possible reason, with parents and service users preferring to push for a referral into a specialist NHS service. So that leads us nicely into the final part of the presentation, where Andy's going to take us through the recommendations, or preliminary recommendations, I should say.
Yeah, thank you, David. So yeah, this again is kind of an initial take on what the evidence is suggesting to us, and based on the triangulation of all that information, and I suppose a logical approach to how we might, or how systems, how regionally, how local areas might potentially respond to some of the things which have been drawn out from those various sources. So just a couple of tables here. Again, I probably won't dwell too much on the detail, but I think once people get to reflect on these again and think about how they might respond to them. So picking out for each of the particular messages and problems that we've drawn out, we've tried to group these things into things that are regionally relevant, or regional responses, and system type responses to each of those. So in terms of overview, clearly there's not much co-design going on, or not robust co-design. So that I think could possibly be led regionally, but obviously local areas have a duty of care to their local populations to consult with them and design their services in response to them. So that's certainly something which has come out strongly, seems to be reflected in the evidence as being effective in producing and delivering sensitive and effective services for certain population groups. Overall, systems really need to just simplify the access, have fewer access routes into services, and learn, as we've said, I think throughout, and there's variation in this, learn from other areas where access is working well, where services are working well for particular population groups. But yeah, really it's about investing in communication engagement with your population to understand what their specific needs are and how services are best tailored to them. So I won't dwell on the detail of those subgroups within that, but there are different ways that people can, regions and systems can respond in terms of deprived groups, in terms of certain ethnic groups, those in terms of transition, and also on the next slide in terms of LD and autism as well. In terms of capacity, I guess some of this information could be used to lobby regions, could be used to lobby nationally to try and generate additional capacity, refunds, resources to try and get more policy, I suppose, emphasis in some of these areas. But also, I think in terms of developing a rounded assessment of what are the needs of your population, particularly in terms of eating disorders, I think is where the biggest unmet need gap is, but also looking at referral pathways and service models in light of those needs. Data analysis, I think David has covered sufficiently already, but there's probably some emphasis that can be placed in terms of analytical resource, in terms of understanding these issues over time, and then in terms of obviously the monitoring, evaluation of particular interventions that might be put in place as well. So much more needs to be done in terms of that, and that can be done again on a regional footprint, perhaps via NHSEI, via PHE colleagues, and also within local systems as well. And that probably follows through the same discussion, the same arguments, I suppose, the same kind of response in terms of that distribution of need as well. So what next in terms of the project and the system response? And I think this is possibly picking up on a couple of the questions that we've seen in the Q&A box. Obviously, we intend, as David said, to publish the regional report in the next few weeks, alongside with data packs for where we can, at least, focusing on the unmet needs and the pathway analysis, looking at individual systems. So for each system, we'll have a set of outputs, all of those charts and more, which kind of give you some of the detail, which you'll be able to then sort of feed into your own local discussion and plans. Other supporting materials include, as I've already mentioned, the evidence map, which is a really useful resource on its own, looking at the consequences, looking at the causes, and looking at the interventions which might be usefully used in terms of this thinking space. More information on the cohort analysis we've done and how that might be used to think about sort of future and longer term service models, and also looking in more detail at a lot of the work you've seen in terms of some of the quotes and some of the issues raised in those stakeholder interviews and service user surveys. In terms of our offer to those systems, we will support each. We've already started. Some of this is underway in terms of the Black Country West Birmingham. We're already sort of early adopters, I suppose, of some of this, and thinking about how they might respond to some of these issues. But again, it's an offer to support each of those systems in terms of facilitating that next step in terms of how they use this to start planning around a strategy or a response to the inequality issues around children and young people. So the untimely issue that we've currently got is that the DSU website is currently under reconstruction, currently undergoing a revamp, so isn't currently available to host resources. So what we've done is we've carved out a separate section within the strategy unit website. So all of the materials from this session today, the recording and the slides will go on there, as well as all of those resources once they're published. We will obviously we'll have a comm strategy to try and push those out via the DSU leads, via social media, via our website and so on. So hopefully we will reach, but please just keep an eye on our website. As well as this, there's loads of other resources, but once you land on our website, that sort of top banner gives you that link to the DSU interim temporary website, I suppose, until we've got that major DSU one open. So yes, please keep an eye out. That's where all the resources will go. So that's it for the formal presentation, and we've just about kept to time. I think a couple of the questions have already been covered off in terms of that next step. So yes, Simon asked, will the breakdown for each of our local areas be shared back? Yes, as I've said, via the supportive materials and resources. As another anonymous, can I have a couple of the slides? Yes, again, that's covered. So David's covered off those two, as well as the next steps. So I can't see, I mean, I would again encourage, I think we'll leave open the webinar until all the attendees have left, to give everyone a chance to, I guess, ask a question that we can respond to either in that or post as we publish the materials, I guess. So yeah, please do contact either myself, David, Abby, in terms of the qualitative and quantitative stuff. And again, just a note to say as well, albeit the project team, the material project team itself was quite large, other people within the unit and outside of the unit, particularly in terms of Tamsin and Swerin, who are engaged in the early discussions about what might be the key issues, what might we want to cover in terms of that qualitative and quantitative deep dives, have been invaluable. Pippa at the CSU as well has kind of talked and walked us through some of the IG issues and sort of through the data privacy impact assessment, which we're mandated to do as part of this project as well. So thank you to all of those people for their inputs. However small they think they were material. So I think that's formally to draw a conclusion to today's webinar. If there's no other questions coming in, there are none in the unpublished list that we've got access to. But yeah, like I say, we will leave the session open. So if anyone who's still on the call has a particular query, please do put it in the thing so we have a register of it. And we will respond if we're sort of still on the call, or if not, we'll have a record of those that will go out with the recording and on the website. So yeah, thank you all for your time and your patience dealing with us. Apologies if there was any background noise on me particular. The council decided to resurface the road just outside of our house from this morning. So again, another untimely intervention that we could have done without, but hopefully that wasn't a problem. So yeah, thank you all for your patience, your time. Please do reflect on the slides that you've heard and gone through today and any of the detail once we publish reports, and please get in touch if you have queries or via your system you want to start developing that process to take this through to the next stage.
Thank you, Andy.